All right, hello again, and welcome to another Down Fracture podcast, a podcast for talking jaws. Dr. Michael Wasson of Arizona Jaw Surgery here with Dr. Sam Bobek of Seattle Jaw Surgery. Sam, how were your travels?
They're good, man. Made a trip to the nation's capital. DC is a cool place. Got to hang out with a bunch of oral surgeons and met some of our listeners. So that was good. I met Omar in person, which was sweet. Um,
Nice.
anyway, there's the good thing about this whole podcast thing is it's kind of opened up doors to meet cool people. So I like that. So that's been fun.
Yeah, I mean, I don't know that I would still do it if I knew what celebrity life was going to be like. It definitely changes things. I can't take my family out without being bothered. Um,
Yeah, I don't
the
think it's
stuff in the mail, you try to
you have
have
a different
dinner and
experience than I do in that regard, but it was nice networking and seeing people. So that was fun. I understand you have to be somewhere this afternoon, so we have to be efficient in our conversations. What do you got going on?
a child has a hockey game, so got to go to hockey.
You play hockey?
I do not play hockey, which is weird. It's hard to figure out how to it was a struggle to figure out how to get all this stuff on because there's a lot of equipment.
I wouldn't even know how to
And
start that. Like there's
I had
layers
to
on layers.
watch, yeah, I had to watch videos like YouTube videos, man.
Can
It
you
was wild. We're a
skate?
few years barely. I mean, I've done it a handful of times. I used to rollerblade a lot when that was cool.
Yeah, I could see you being like Happy Gilmore, out on
Yeah,
the court or the
the
rink.
rink, the rink or on the ice. Yeah, well,
Well,
it's not
sweet.
a
We got to
bit.
get you to hockey practice. Let's see. What's our topic today?
Think we're going to do hardware removal, just since we kind of have a quick one. That seems to be a useful topic that we can hopefully rock out pretty quick.
Yeah,
What do you
this
think?
is a dirty word, right? Like it's a couple dirty words. Hardware removal is something no one wants to talk about.
I love talking about it.
Yeah, do
Um,
you what words are similar to hardware removal when you see that on your schedule of some surgery that you're doing? Like
um,
arch bar removal?
possible, I've seen a couple possible non-unions or things like that
Yeah,
other
maybe.
people have told them they have those
I mean, hardware
certain
removal
people's
is just
names.
it's not fun. I don't think patients like it. Providers don't like it. There's just really there's an occasional satisfying hardware removal, but generally speaking, this isn't necessarily fun. So
Nope.
let's see. Why do you take out hardware? What situations do you do it?
Good question. Most of the time, I would say it's persistent inflammation or infection.
Okay.
Like the patient had like a persistent parulus or swelling or drainage or something like that. That's been, I think, the most common situation I've encountered recently. There's the more obvious or blatant ones of revision for other purposes or non-unions, as we kind of just touched on a little bit. But I'd say the most common for me is just common inflammation or infection around a prosthetic that after a round or two of antibiotics just isn't getting better.
Yeah, I've kind of perceived hardware removal to fall into two time categories, like a lot of things, the kind of early and late hardware removal. The early hardware removal, what's the earliest you feel comfortable taking out a plate or a positional screw or something like that?
I mean, I think that's a great question because I don't think we know. I generally try to wait to about 3 months if I can.
Yeah.
But I mean, but my rationale for that is I want the bone to heal so that it doesn't need the hardware, so that the patient can be propped open and tolerate a procedure. But I think you could make a case for the reality is if there's persistent inflammation and infection, that's impairing the bone healing. And, or at least in that particular area, you hope that it's healing in the other areas. But if that's going on, I think you could make the case that healing would be improved with the removal. What do you think? Are you
Yeah,
similar
no,
or do you do
I agree
something
on that.
different?
I feel like we've talked about this one before. So yeah, letting the bone heal. But I mean, if it's obviously causing more problems than it's helping, getting it out of there is good. 3 months is a nice little threshold. I feel like people on the patient side think that they need longer time for it to heal. But it really can cause a lot of damage. I mean, there's times where you have a lot of granulation tissue around, let's say a mandible plate or um, like a buttress plate in the maxilla where, it causes a lot of bony resorption. And the reason for why it's in there has been lost entirely. So getting it out is useful. And honestly, once those screws aren't holding on to bone, what is it doing for you anyway, right? Like it's
Exactly.
only harming in that it's causing further loss. I don't know. I'm of the opinion that in mandibular plating, it's generally the proximal segment hardware that gives up first. It isn't always the case, but generally speaking, it's those two screws. And if they're not holding onto any bone, the plate's not doing anything at that stage.
Yeah, I completely agree. I think the concern is more along the lines of putting some more stress strain, if you have to put a bite block in and you're pulling on
Yeah.
things and you have a little bit of caution with that. But yeah, that's kind of the case that I make to patients is like, hey, if it's being a problem, it's not only is it not doing what it's intended to do and providing you assistance, it's making the environment worse. And so the sooner we can kind of get that out of there, the better. But sometimes, one of our topics has been limited mouth opening after mandibular surgery, especially. There's a lot that goes into it that sometimes they're just not ready for a procedure. And it doesn't mean you have to put a bite block in, but sometimes that makes life easier. So I
You
think
think putting a bite block in helps you remove hardware?
no, I mean, I think it might help you initially with like dissection and stuff to have the mandible stable. But I think when you actually have to get that far back to remove it, I think having them close down or be relaxed is the way to go.
Yeah, yeah. I feel like there's some tips on removing hardware. And before we get to that, are you taking hardware out in your office mainly, or are you taking it to the OR?
It depends. That's a conversation I have with the patient because my practice is a little different than most people's, as I've said before, in that I don't really sedate people. Like I haven't sedated anyone myself in my office. And so it's either bring in an anesthesiologist in my office or do it under local. So I've done it a handful of times under local, and depending on where it is, that's not easy on an awake patient. And so,
Yeah, that sounds
plate,
even worse
you know,
than
a,
taking out hardware in the first place, right? Like
right.
now I'm feeling twice nauseous. Hardware
Yeah,
removal under local.
I mean, it's not something anyone can do. It takes a really skilled practitioner to pull it off. Um, but luckily, that's not a problem in
That's the problem.
Arizona. That's a
Yeah,
Seattle problem.
yeah,
Um,
exactly.
but taking out a plate is easy enough in the clinic. But when you've got positional screws that need to come out, doing that under local is what some people would call no bueno. And you don't want to be putting a trocar in again. You don't want to be going transfacial again. And luckily, most of the time when you're removing hardware, it's not in there solidly. And so you can either take a hemostat or something curved clamp of some kind and kind of rotate it a little bit, wiggle it a little bit, and get it out of there where you don't necessarily have to engage a screwdriver.
Yeah, the
Um,
definitely the good news of positional screws or lag screws is that they hardly need to be removed, right? I mean, if you leave them long like they do in Arizona, where the screws are inside the mouth on the lingual aspect, sometimes
you
um,
can't get the lingual
they need to,
nerve if they're flush with the bone,
yeah, so
Sam. How
sometimes
many
they need to
times
come
do we have to talk about that?
without joking aside, that does happen, right? Like, I mean, it's
Absolutely.
that can happen. I mean, whether it's in the healing process that some bony resorption comes in and all of a sudden the end of the screw comes out. You intend to know the length of the screw based off of um, the drill that you're using, but it may be that you end up having a little bit too long of a screw. So honestly, positional screws, that's probably the main reason to take them out. But in terms of doing it in the office, I generally try to take out hardware in the office as much as possible. It just makes it less of a big deal. Because with hardware removal, the cost of it comes up, right? Like billing
Absolutely.
insurance and how that works out and making it go to the hospital is a whole thing. So I think as best you can, if you're doing it in the office, I think a big cheat is not using a bite block. So
Mhm.
I felt
For the
like
for the mandible. The
for
mandible. I
both.
mean, I guess for the maxilla, it probably is useless, but
Yeah, no, I mean,
that's
not having a bite block in there allows the lips to stretch. I mean, while at least mandibular hardware, just plates on the Delpont, the proximal screws are generally the loose ones, but that's not always the case. I generally think in terms of tricks of removing it, not having a bite block is one of those tricks that helps out a lot. I think, the plate's usually around the nerve. So, how the patient's recovering from the neurosensory recovery is something to consider. Um, because that the distalmost hole can be right around the metal frame, and just dissecting that, you need to take that into account. Obviously, the concern of how much nerve was exposed in your Dalpont, right? So if um, you didn't really have much to cover that up, the dissection of the plate itself, you have to be wary about injuring the nerve in the osteotomy side or the previous osteotomy side. I have met a patient where they had a nerve injury from that aspect, so from hardware removal. Um, that's something to keep in mind.
Was that you? I can't remember if it was you or someone else who has talked to me about utilizing a bovie on a plate in close proximity with the nerve. Is that what you're referring to, or am I getting you mixed up with somebody?
I'm not sure if I said that one. But the plate when it was placed, particularly if you're moving someone else's hardware, right? Like, I mean, if you are, you know how you put plates, and if you're, I would encourage people not to leave a nerve hanging out in the Dalpont for this very reason. Whether they place bone graft over it, or whether they put fixation over it. The removal of the fixation, dissecting that out can cause a nerve injury, right? Because the nerve may be outside the mandible in a new area at the Dalpont, and it's hard to tell what's nerve and what's scar tissue on hardware removal in that location. So,
Yep. For sure. And then I would just throw this out there because I thought it was you and you were going to get to it, but maybe you could speak to this or you have experience with it. It hasn't been anything that's happened to me to my knowledge, but someone at some point in my career has told me about either they themselves feel that it caught that they did it on one of their cases, or they saw a patient where for whatever reason they were suspicious that utilizing the bovie down to metal and the nerve was in close proximity, bovie onto the plate or the hardware with nerve in proximity caused a nerve injury. So
sure.
I don't know this to be true, but I mean, in some ways it makes sense.
I mean, I can believe
Um,
that. But
yeah.
I mean, generally speaking, hardware removal, at least in the mandible, or actually maxilla, if it's infection related, there's granulation tissue. You're making
Mhm.
a vestibular incision again. The granulation tissue takes you right to the plate or the screw. That's the culprit. And it's
Mhm.
more making sure that you get all that out of there without causing more trouble, right? Like,
Right.
you remove the source of infection, or the loose screw or whatever it is. And so I generally treat it like um, cheating on either side, right? Like finding the extremes of the hardware where I know the anatomy is. So the spots where I'm not going to get in trouble with the nerve. And I'm really not Bovian much at all. It's like a very much dental alveolar case where I'm just making an incision in the vestibule and dissect subperiosteally, and then come at the middle area essentially. And then once you get the plates and screws out, um, cleaning that out as best you can. And I think another tidbit that I've learned with reps is undermining your flap. So getting a tension-free closure, but excising the scar tissue otherwise. So that the buccal flap is really just kind of closed to this mucosa that's good. Because at least an infection, the mucosa is in bad shape.
Right.
Yeah.
Yep. Yeah,
So
and I think you talked about debriding it, and I think maybe this goes without being said, but I think it's worth saying in case someone would overlook it. But I think you also have to examine the bone where your screw came out, like intentionally, because sometimes there's loose fragments of bone.
yeah, yeah,
When I've taken out positional screws, I've found that to especially be true.
yeah.
Like you wiggle out the screw, but the bone around it is sometimes it doesn't clearly come out with the screw, but then you start curating it a little bit, and you can see it's moving and you have to be somewhat intentional because you don't want to leave crappy bone behind and then you got to go back in again and take out sequestrum or you're dealing with sequestrum. So I think being intentional about that is a lesson I've learned over time. What about maxillary hardware? Are you done with, you got anything else on mandibular hardware? Or do you?
Well, yeah, the early mandibular hardware, I don't have too many other tips other than to make sure it's all out. Counting your hardware, and having a closing count on hardware is a pretty good tip. Because it's easy to remove 3 screws and think you removed 4, right? So
Mhm.
just making sure, and you have help in the room, that you get everything out of there that you intended. Maxillary hardware, do you open the same incision?
It depends on what all I'm removing. If I feel like I'm removing all of it, then yeah. If it's more localized. I might cheat a little bit, but I feel like you almost have to sometimes if you're
I'm just
removing the entire plate.
I'm a little
Like, yeah,
partial to just lateral incisions, just not
what do you
making
mean? Like not crossing the midline? Is that what you mean?
yeah, not
Yeah,
making
yeah,
a LaFord incision, just making lateral incisions, so making two incisions
right.
from maxillary hardware. I mean, one, it's um I think it makes closure a little bit easier in terms of not having to manage the other base as much. But you can also just kind of manage the individual plate that you need. Generally speaking, I'm not a fan of just taking out the inferior aspect of the hardware, which honestly, with early hardware removal, you should probably just take the whole thing out. Um, and I think making lateral incisions helps allow you to dissect it a
Yeah,
bit.
that's what I thought you meant, like a vestibular incision. But yeah, I completely agree with you. If you don't have to cross the midline, that's helpful. But I do feel like you have to make it like you can't just make it right over the plate or like make it small because it's already scarred down. You've got to still get high up if you're taking the whole thing out. So I find that my incisions on in the vestibular for each side are pretty similar. Sometimes I feel like I even take them a little further back because I'm not crossing the midline. So I might go to the fours or the fives more as
Yeah.
far as the laterality of my vestibular incisions.
Yeah. I think
And I
in,
think you have to be careful there with bone gaps. If it hasn't filled in well, you can lose screws down into the maxilla.
oh, yeah.
So I think if you can pack something around there to prevent that happening, I think that's a good idea in
And
general.
I'm a big fan of maxillary hardware removal on taking the screws out as you see them. You don't need to expose everything. Just if you see a screw, take it out, hemostat, make sure it's out of there, get on to the next screw, right? Like you don't need to find all the hardware and then start removing it. I think dissecting to the top part of the plate and just having a periosteal over the top of the plate or a freer and not even needing retraction, honestly, and taking that top screw out is good. Opening things up like you're doing a LaFord again, I think is overkill when it comes to maxillary hardware. And remembering,
What do you mean? You're talking about crossing the midline, full dissection, or do you
yeah,
mean
like just opening everything up, like making a big operation out of it. I think making incisions that are over the plate or lateral incisions and then dissecting along the plate. You don't need to see everything. As you expose everything, you open avenues that you can lose screws into the sinus. You open, um, I think you just open up more trouble than you need to. And so if you get to the hardware itself is good. So I think maxillary hardware is always longer hardware removal, especially with custom plates, by the way. So custom plates is a bigger operation. It really becomes a bigger operation. I think the uh my understanding at least is the literature either exists or it's coming out to exist that custom hardware has higher rates of hardware removal. And it's not only that, the hardware removal itself is more difficult. Like it's a bigger plate and it does lend itself to having to need a bigger incision or at least cutting the hardware. So
right?
um I think for most early hardware removal, if it's a big custom plate or if it's a big like recon plate in the mandible, maybe that's a OR case.
Yeah, kind of getting back to that topic, I don't know that I ever answered your question, but I generally try to do them under local in my office. But I try to be very candid with what that's like. And, most of the time I'm telling them it's the retraction that's going to be bothersome to you. Like I'll get you numb, it's not going to be pain. It's going to just be unpleasant to have things tongued on. And so some of them are leery of this. I tell them, taking out screws doesn't hurt. Taking out this hardware is not going to be painful. And so some of them are leery of that and they want to go to the operating room, which I totally get. And so sometimes we go to the operating room for these things.
Yeah, I mean, what I'm getting at is I think you need general anesthesia if it's going to be a bigger operation, obviously.
Yeah, for sure.
But I mean, sedation in your office, like wisdom teeth sedation, generally covers most of it. I don't think you get that much bleeding in the sinuses with maxillary hardware. Mandibular hardware,
No,
airway management is very straightforward. Chin hardware is the same, by the way. But early chin hardware is pretty unusual. Late hardware removal, it's a different animal though. So like the late hardware removal, do you get requests for that?
for the chin.
Well, in general, because we've been talking about the early stuff, which is largely infection or loose hardware, right? Like, you're taking it out. I mean, in the setting of taking it out in face of a non-union isn't what we're talking about. It's primary hardware problems, whether it hurts or whether it's causing infection. In the, let's say, first year of recovery, generally can be managed like we talked about, right? The later hardware removal, whether that's with revision, whether it's because screws are exposed in the sinus that are causing infection, whether it's screws from the positional screws that have found their way into the mouth, I think are a different animal, right? PAP masks pushing on the hardware. I've seen that one. I've seen hardware move later, like a late mobile hardware, or even at the time of revision. So that's a different animal, I think, in terms of hardware removal. What do you think?
Yeah, I haven't dealt with that as much. I have a couple of times with people who just usually, thin females who still feel like they can feel plates, and so they just want them out of there. I think that's been the most common scenario for like late hardware removal, other than revision that I've
Oh,
dealt with.
real quick, since I brought this, sorry, I think I had one more nugget. What's your favorite screwdriver to remove hardware? Do you think you need the same screwdriver for whatever plating system was
I
placed? Like you need a striker mid-face screwdriver to remove striker mid-face screws and a KLS mandibular. You know what I mean? Like, do you need
I
to
always
track
request it.
down?
I don't know. I mean, I'd be interested to hear your take because I always intentionally request it. Like, hey, I'm removing your hardware. I need your, some of them I have already in my office. Like I have their screwdrivers just from use other times, but I generally do make that request of, hey, I'm taking out your, to my reps. Hey, I'm taking out your hardware in the mid face or the mandible. Can you get me a screwdriver for this day and I'll sterilize it and get it back to you or whatever. You
Yeah, I
don't find
mean,
that that's necessary?
before we get into the late hardware, un, I've lived a life of using a lot of different hardware. That was not by choice, by the way, just because my hospital system changed vendors over the course of my professional career. And I've had the opportunity to have way too many different types of screwdrivers exist in my office. And honestly, for hardware removal, I find the Synthes screwdriver to remove everything.
Hmm,
There's like tightening screwdrivers, but generally you can get the hardware that you can get the driver that you placed it, but Synthes is a good backup. That it's so
interesting.
solid. It's pretty much can remove anything because they're generally cruciform hardware in terms of the screws with all the major vendors if it's newer stuff, and that one's a pretty good middle of the road. So if you had to, I don't know, if your vendors are mean and they're not hooking you up with screwdrivers to help you remove the hardware, because by the way, reps suddenly disappear when you're taking out hardware, right? They're there to put it in, but they don't care too much about it coming out.
Yeah,
So if you're generally they're nice and they hook you up with a screwdriver blade if you're taking it out. But if you're running into trouble, I would say seemingly the universal removal device is a Synthes screwdriver. So
interesting. That's good to know. I mean, I do. I had this issue with IMS screws because they were from
yeah,
Stryker because they recently switched those. I think at like the beginning of 2025, and I was like tormenting people trying to take them out in my clinic. I
yeah.
was like, no
I
one
just
wanted to
got
give me a heads up.
I just got the KLS screwdrivers for the TAD removal in the office. Anyway, we have too many screwdrivers in the office. It's just if you were in a hard place or if you thought you needed to purchase a big hardware removal kit for your office, there's some universal ones. Which is
Hmm.
getting to the long-term problem. Like one of the long-term problems, like the late hardware removal that we're just about to talk about, is
Hmm.
that you can run into hardware from the 80s. You can run into Russian hardware, right? Like you can have people show up and they're like, I had a two jaw in South Africa. What do I do? And you're like, geez, I don't know what they're using. So
Right.
I think one of the more the sneakier things of late hardware is that you may not have the right driver to remove it. So
Bone, bone being over it that you have to remove can take some time if it's been a while.
Bone going over the
Um,
top is a problem.
yep. And then I had that situation recently from someone who had surgery in Turkey, and it's like, well, I don't know what they used. It kind of looks like this. I sent some images to reps, and they think, well, I think that's ours. And then I just was like, can we just get the universal driver kit? Can we just have that in the room? And that worked for
Give me
me.
some
But
tips on taking out old hardware. You got any that you figured out over the
I
years?
mean, well, I think to remove bone, if you can't just quickly get it with a periosteal, taking a burr can be helpful. Um, but you also have to be kind of leery of damaging the screw hex on the screws to where you can strip them and other things. Otherwise, they can be problematic. They can really kind of be in there. They can get the bone over, and we talked about that. I don't know that I have any tips. Sometimes I feel like when I go in there with that, I feel like I'm just going down a pathway of doing what I have to, um, which a lot of
Yeah.
times can be removing bone, either with periosteal, with a osteotome. Sometimes I feel like sometimes that works pretty well if you can get a straight osteotome onto it at an angle. If you're trying to get it started, I feel sometimes that using a burr away from the screws, so you're not going to damage the screws. So like on areas of hardware that's covered in bone that don't have screws, get it started with a burr, finish it with an osteotome over the screws, take the screws out, get an osteotome under the plate if you are having trouble getting the screws all the way out or loose. Got to get those moving. I'm trying to think what else I've done. You
Yeah.
got
I
anything
mean,
else other than that?
I think that I'm doing a revision case, and I tell people if it's an older revision, right? Like over 10-year revision case. I tell people I'll know really quick if it's going to be a fast surgery or not, based off of how much bone is over the hardware. And so if you get in there and it's like everything's covered in bone, you got to find the hardware. I generally like removing the hardware. I know people sometimes just cut through it, but I like taking it out of there because I want to put new hardware in. And if there's old hardware in there, I gotta find it. So I think removal of bone over the hardware is difficult because like you're saying, like taking a round burr and removing bone next to it and kind of like chiseling it off, I think is a good tip. Trying to maintain the screwdriver mechanism so that you can get something in there. The universal kit from KLS, I shouldn't say just a screwdriver. We're not sponsored by these people, by the way. So uh the Synthes screwdriver is pretty solid. There's a black handle KLS screwdriver, by the way, that also functions as a near universal screwdriver. But there's universal kits that exist that are out there.
Exactly.
The
Yep.
orthopedic ones seem to be not very helpful. And most of the kits, like the ones that they have at my hospital, at least, like they have 10 different screwdrivers that I would never use, like variable star mechanisms. Have you ever used a star drive mechanism to take out a screw?
I don't think I have, but I actually got to run. You got anything in closing that you'd wrap this with?
You're like, get done with it. Okay. So yeah, so
Get out of
in
here.
terms of your
Get to
hockey,
the
you
meat.
got to get it done. I would
Yep.
say that chisels into the cruciform mechanism and using the flat handle screwdriver is a great trick. Just using a wire driver and backing it out, like disregarding it and then unscrewing it with the wire driver. And then sneaky one is the backside of your screwdriver handles can work.
Huh. I hadn't thought about that. I was going to throw out there that I've cut plates into so many pieces before, so that I can then grasp and kind of rotate them to loosen them. The downside to that is I think sometimes you can end up removing more bone than you want. And if you have to replace fixation, that could be problematic because now you have less bone to work with. But
Yeah.
I've,
Yeah.
sectioned maxillary plates especially so that I can like grasp them and pull up a little bit. I've done some wild stuff, man. Out here in space,
Yeah,
you can
space
do
hardware
some.
removal is crazy. You just create more problems. But yeah, I think generally at the end of the day, just getting down and taking a wire driver to it is reasonable. So
Yep,
I wish I didn't have as much experience taking out hardware as I do. But that's a good one. I hope there's a couple tips in our abbreviated, quicker version of the Down Fracture podcast today.
me
Uh,
too.
if not,
If
that's all right. We got to see you in
I
space,
mean,
which is
like I
great.
say, if not, like I mean, do your own podcast if you're going to complain. Like you
Yeah,
get
I
what you
mean,
get.
a little
You get what you
confrontational
get.
there, I think. Um, I think anyway, it's a good topic. Hardware removal, having a game plan for it, and just kind of taking out the right amount. Not too much, not too little.
All right. Well, that was another Down Fracture podcast, a podcast for talking jaws. Down Fracture podcast at Gmail. I'm gonna run to hockey. I'll see you later.
Catch you later, dude.
See ya.